السلام عليكم ورحمة الله. I want to take this كلام بالعربي والله. وقفة. الشكر الجزيل للدكتور أحمد عمار، بروفيسور أحمد عمار. Maybe you don't know إن لما أنا خطر في بالي أسوي نيوروسيرجري رحت سويت انترفيو مع الدكتور أحمد عمار في الشركة. فأنا كنت جونيور ريزيدنت. ودكتور أحمد عمار كايندلي كان في معادني بروفيسور حسين الدكتور عبد الوهاب وواحد يا احمد انا شايف فيك مستقبل النيوروسيرجري في السعوديه. قلت له احمد انا مستقبل النيوروسيرجري في السعوديه وانت عز الله ما في مستقبل. لكن the thing that I really realized when I met دكتور احمد التعامل الابوي ما بين بروفيسور واليوم نيوروسيرجيكال ريزيدنت. I tried to mimic it بس فشلت. Ahmed Ammar is a real icon in Saudi Arabian neurosurgery. He graduated generations of neurosurgeons. من بداية ما بدأ الكين فيصل fellowship program إلى الآن and he is to continue. تحية أكثر من صح. All what we see today is nothing but a continuation of what he started initially, something like 20 years ago. I don't want to say 20 years ago, but unfortunately it is 20 years ago or more. And of course, Dr. Abdurrahman Al-Anizi, a close friend, أكثر من close friend. He asked me to talk about pain, and our chairman here said, Ahmed, go to the basic. And I don't know what basic is, but we'll go to the basic. So if I feel that I'm going too deep, just ask me to stop. Go back. So he asked me to talk about pain. Remind you, any patient will go to the neurosurgeons. Will come because he has a seizure, has a pain, has a neurological deficit. So pain is like 1/3 if anybody will come to your clinic. And pain is very peculiar in a way. Let's take an example. Somebody hits you here in your hand. Well, it's okay. Somebody else will feel like, oh, pain. You cannot evaluate the pain. It's what you feel as a patient, not what I can judge as a doctor. So it's extremely subjective, and any objective measures to tell that this patient has improved in his pain is okay. It's a battery that you can go through. At the end of the day, it's the patient's satisfaction. If he feels the pain is gone or not gone. So, don't look at these pictures because this could be someone who just wants a candy. And this one is only in training. And this guy is the happy guy. Was having more pain, but he received the pain earlier in his life, like the neurosurgical resident. When I want to talk about introduction, it's very important to divide two things: nociceptive pain and deafferentiation pain. If we go from this presentation by this classification, that's more than. The first one is there is a cause, an action, and an effect. You bring a pain, you hit me here, ooh, this is painful. Okay? So it's activation of receptor. And this happened with cancer pain, trauma, osteoarthritis, you name it. So you stimulate a receptor, transmit to the brain in a healthy central nervous system. The brain will receive the signal as pain through the right channel. The second one is deafferentation pain, which means what? The nerve itself is sick. So even if you touch the patient on his hand, the signal that will go from the skin receptor to the brain did not got there in the right way, the right direction, the right amplitude. The brain doesn't know what to do with it. Well, this is not usual. So that means there is something wrong. So let me give an alarm and cause pain. And this is what we call it deafferentation pain. So you have a trauma with a cut of the forearm. The neuroma in the forearm receiving some sensation, not in the usual pathway to receptor, peripheral nerve, brachial plexus, and spinal cord. It will get to the brain centers. It's not the right pathway, it's not the right signal. ما بيتكلموا عربي زي ما أنا فاهم، بيتكلموا بلهجة مختلفة. Well, يمكن بيقول كلام وحش. So this is the affrontation pain. If you got this slide, I'm very happy with all what I'm going to talk about later on. How can we treat that? Conservative or invasive? Not going to spend too much time on that. Physiotherapy, medication, biofeedback may be the most ever important. And alternative therapies, when you go to Chinese and you go to herbal, which is measure شو اسمه تشيك يسووا لك من عبليش بالطين بالحراره بالمياه المعدنيه. Invasive like nerve block. This is one of the most important things where you have action, result, conclusion. Spinal cord stimulation, I'm not going to talk about that, but I'll give some hints. Intrathecal medications and brain stimulation, which is going to be the topic of today. But we'll take it in a way to understand the mechanism rather than in a clinical details or in a surgical details. When we go to the brain, we either do deep brain stimulation or we do something called motor cortex stimulation. So why do we do that? We want to go to the brain itself and tell him what you have felt, what you received as a signal, just ignore it. Or what you receive as a signal is not that important, keep you busy with something else. So if somebody who had lost a father or a husband, what you go to him to do, you talk about something else. So he can forget the agony that he's on. True? So, everybody who has a pain should come to Dr. ALkhani to do cortical stimulation. If you have 1 million who has pain, maybe one will be a candidate. So make 100% sure that all other modalities have failed. And now you talk about super selective patients where nothing else can help. Let's talk about neuromodulation for pain. To do that, you have to make 100% sure that medical, surgical, psychological, pain specialist has seen the patient with 100% sure there is nothing non-invasive or less invasive can be done to help this patient. At least 6 months of pain that's not going up and down, rather constant or progressive, severe enough to affect lifestyle, and the pain is the major problem what we see instead of other like seizure, like neurological deficit, or depression, and the pain is only a way for the patient to express himself. No question, no patient should go for pain procedure in the brain without good psychological evaluation. Depression is not a contraindication. All of them are depressed because of pain. The problem is some people lives with their pain. So he goes from hospital to hospital, he has a pain, he has a pain. If you leave the pain, there's nothing to complain of. That's no good. He has to go to the doctor and see him, say, well, I have pain, you need to help me. And of course, hysteria. By far the most common in our community, by far any community. I don't want to be racist. Let me start with motor cortex stimulation. What's the principle of it? This guy, for people who came from Montreal, Penfield, he went and resected the sensory cortex. It did not help. He went and resected the motor cortex, and that helped the pain a lot. So somehow that precentral, postcentral, motor cortex, sensory cortex is not like written in black and white. Postcentral gyrectomy resulted in only 13% improvement in pain. But precentral, quote unquote, improved in 2 patients. And then, I think that's in the 90s, they introduced the epidural. So you go to the motor cortex, instead of resecting it and causing paralysis, you stimulate it in terms of neuromodulation. That's what we are doing now. I mean, don't take this word, good to excellent. I'm going to come to that later on. But at least it could help. How we do that? The answer is we don't know. Let's speculate, let's think about it. Well, maybe it inhibits something in the thalamus, the spinothalamic tract. Maybe it stimulates the periaqueductal gray matter. I'm going to talk about this in a few minutes. Maybe it increases the cerebral blood flow, helps in better oxygenation to the area, and allow the brain to understand the signal in a better way. You don't need to have a normal spinal cord. You don't need to have a normal internal capsule. You can go to the end results, where people are understanding the message and tell them, okay, either make you busy with something else, or assure you that whatever you are receiving is of no value. Let me take an example. 58-year-old female, she has atypical facial hair, so it's not trigeminal neuralgia. All the medication list that you know about trigeminal neuralgia has been tried. Glycerol injection, and then being defined as atypical neuropathic pain. Let's listen to that lady, what she's saying. سامعين الكلام؟ How much? 10 out of 10. يمكن يوصل ل7 مع الأدوية ويرجع نفس الشيء. So it's not really trigeminal neuralgia. Listen to that word. When you ask her what's exactly the real thing, I think we missed it in the first sentence that she said, EL-Hadi. Once the patients tell you the word, it's a burning sensation, going through whatever, disc surgery, carpal tunnel, you know that you have now an injured central nervous system or injured nervous system. Whatever you're going to do, the message that will go from the receptor to the brain will be altered. And your pain may never be resolved completely, maybe help. Let's see what we can do for this lady. Take her to the OR, draw the brain, use the facility, use technology, vector vision, see exactly where is the sylvian fissure, where is the central sulcus, where is the motor, where is the sensory. Small craniotomy, using neurophysiology, and then put the small electrode over the dura. You can open the dura and put it under the dura. It doesn't matter. You can even stimulate to know exactly what she is complaining of is the face. So we go and stimulate on the hand. We go more lateral on that gyrus to reach to the face where she is complaining, and then implant the electrode and stimulate later on post-op. This is an X-ray. Another patient has a brachial plexus avulsion with severe neuropathic pain. same story. Working in a factory as a blast, lost his brachial plexus, severe pain. We went and did for him cortical stimulation. And then after that, like what we are doing with movement disorders for years now, you do good programming. Many people outside, they do trials. Like they put the electrode as outside trials, see benefit or no benefit before they put the batteries. I don't do that to reduce the chance of infection and to have the chance for the patient to understand what to accept. Visual analog scale, I don't say it's useless, it's the way you want to read it. So, if I'm okay, you go here. If I'm crying, well, you're not going to cry 24 hours. So that analog is a bit iffy, but at least something that we can measure. How much should rate 10 out of 10? 10 out of 10, 8 out of 10. The patient can tell you. So, this is cortical stimulation for pain. Let me talk about deep brain stimulation for pain. Maybe it's more history in this, since they started to do deep brain stimulation in the 50s and the 60s. They felt that if you stimulate the septum pellucidum, pain may get better. Good. If you stimulate the caudate nucleus, the pain may get better. Very good. Let's see how reality is. Recently, in the 90s, when we start to do deep brain stimulation for motor disorders, the improvement has been quite big than before. So people start to look at the old indications for deep brain stimulation. Well, now we have a good neuroradiology, now a good neurophysiology, now we have a better neuroanatomy understanding, better neurophysiology understanding. Let's apply the old indication to the new technology. So in 1969, if you go to the periaqueductal gray matter, you may be able to do surgery on a rodent without having pain. That will come us to the gate theory. Who hasn't heard about the gate theory? Anybody heard about the gate theory? Put his hands up. Gate. Okay. So, these two gentlemen put a nice, simple theory, saying you can hear Arabic and understand what he's talking, and you can hear some Chinese and you don't read Chinese, and you know what to do with it. So if you receive Chinese and that's painful to you because you don't understand it, one thing to do is let him hear Arabic and he will forget the Chinese. If the sad song is bad, put up the nice song and he will focus on the nice song. Simple. So, the bad pain fiber will compete with the good sensation on the gate that goes to the brain. So you keep him busy with something else. And this is what the gate theory is all about. I mean, I don't want the audience to stand up and say, well, it's old stuff. Maybe old, it's not 100%, but it's still run a value of why we are doing what we are doing. So, bad people stimulating the brain, and instead of that, let him feel some, not a pleasure sensation, but normal sensation. He will forget about the bad sensation. I'm trying to make it simple. Two areas were currently underused. One is to go to the thalamus for the spinothalamic tract. You put your electrode, you stimulate, you block the bad message that goes to the brain. Gate theory. Or you go to the periventricular gray matter or periaqueductal gray matter and stimulate, and all the studies show if you do that, you will increase the concentration of opioid, the endorphin in the CSF. So you give the medication to the patients. So either you go to the thalamus for spinothalamic tract that will go to the cortex, or you go to areas where stimulation will lead to release of endorphin. This is nice, But you need to go to the right nucleus in the thalamus. Well, nowadays, why should you go to the small area in the brain? Since the end results will be to the motor cortex, stimulate the motor cortex. I don't do this anymore. But some cases, when the pain is diffuse, where you cannot point a single side where you want to do stimulation, like atypical facial pain, like avulsion of the brachial plexus, you can go to the periaqueductal gray matter, or you can go to the periventricular gray matter and stimulate, resulting in internal opioid release. Exact mechanism is not 100%, but for the thalamic one, it's indeed spinothalamic tract. And for the periaqueductal gray matter or periventricular gray matter, it is the elevation of endogenous opioid, like endorphin. Not going much into the surgical technique, but exactly the same what we do for moving disorders. We put a frame, put an electrode, identify a target, go with the electrode, some neurophysiology if needed, and stimulate. And of course, post-op tracking of programming. So, which patient gets helped by this is the nociceptive pain, not the deafferentation pain, because we are treating this with opioid. True? It's a patient that we did with periventricular gray matter stimulation, and then we implant the battery. Post-op, better, not better, better, not better. We'll talk about that. Ronald Tasker, the greatest ever pain neurosurgeon, who wrote the book called Pain and the Neurosurgeon, and it's the impact and functional textbook of neurosurgery. Failure is 65%. From the people that get internalized, 50%. We don't do external stimulation. We just go directly and implant the battery. So we should expect something like 65%. This is King Faisal, not Ronald Tasker, the greatest. So it's iffy. It's the last ever result. In summary, 60 patients who pass the trial, 60% may have some reasonable improvement. That means 36%. Complication, I don't want to go through all of this, but could be surgery related like hemorrhage, neurological deficit. Could be related to hardware like infection and disconnection. And could be stimulation related, which is the easiest part because you can turn it off. From all the studies, I believe what Tasker said, it's a huge amount of possibilities, especially with pain patients. So I want to conclude that it's not without risk. So, when do we do that? If it's really refractory, if really no other way to do things, let's go to that brain stimulation. Let me go back to square one. If you go out from this by saying pain is neuropathic or nociceptive, this one will go by cortical stimulation, or if you're interested in thalamic stimulation, how we treat. Nociceptive pain will go by releasing of internal opioid by periaqueductal and periventricular gray matter stimulation. Either are options, not only options. Last ever option to talk about. Failure can be patient selection, patient selection, patient selection, patient selection. Not a neurosurgeon, definitely a psychiatrist, definitely a psychologist. Is the message I want to give today. However, some people may ask you about epidural spinal stimulation. From what I said, most likely we are talking about what? Paresthesia-inducing relief. True? True? So it's same like cortical stimulation. Why I don't do this? Because in our department, anesthesia does this. Carries a lot of X-rays, too much X-rays. You have to think about that. So, they go epidurally and insert an electrode with a battery to give paresthesia. Same what we are talking about Arabic and English. The bad song and you increase the good song. So the patient will feel happy and does not listen to the bad one. I don't do it myself, but I'm more than happy to answer any question on this regard, to understand the principle of it, if you are interested. The second one is the intrathecal release of medication. Baclofen for specifics what I do, but our pain specialists also use it for morphine, also use it for like handful of medications, extremely strong. I don't like myself to get involved, but there are definitely options before we reach to the brain. And from just hearing that, it's equal to periventricular periaqueductal gray matter stimulation, because you are treating what? Nociceptive pain, true? Like cancer pain. Thank you very much. As simple as it can get.
Yes, very simple and sticking to the time, just 5 minutes.